All right. Good morning, everyone. Welcome to Cardiology Rounds. David is at Division Head Meetings and has asked me to introduce this morning's speaker, someone who is familiar to all of us, Dr. Glenn Geiger, who is our Chief Medical Information Officer. And as you know, he's been instrumental in how we've implemented EPIC within the Heart Institute and the Ottawa Hospital. Really, it's been a lot of work for him and the team. And he is here today to give us the EPIC updates, and there are a few that we should know about. And I'm sure there'll be time for plenty of questions. So without further ado, I'll hand it over to Glenn to take us through the update.
Well, thank you for asking me. That was a nice introduction, but I think you know me from EPIC in lots of different ways, some good and perhaps some not so good, but that's okay. I'm planning just to give you an overview of information about the project, where it stands today. I'm going to obviously leave time for questions because I think questions and feedback are a fairly important part of the process where we are today. And we'll see if we have time for sharing some guidance about what further training is going to be available and what kind of tricks you can use to be more efficient with EPIC. So we'll cover a little bit of that and see where that takes us. This is what I suggested I would review with your group, the governance model for the project. I apologize, some of you may have seen some of this material in other forums, but nevertheless, I find it's important to share because I speak to many physicians who seem unaware of the governance model for the project, or they think somehow I'm in charge of it, and that is definitely not the case. Then I'll give you a little bit of an update about what's going on right now. We're in a fairly busy period with Project Fusion, and that has had an impact on other types of activities we've tried to do. I usually spend a little time sharing some of the data EPIC has about physician proficiency in EPIC, and I'll give you examples of what some of that functionality looks like. And then we can talk a little bit about things you might want to follow up on as you move forward and out of the pandemic and out of the current EPIC build activities that are going on right now. So we'll start with Project Fusion governance. As I said, some of you may have seen this material before, but I do think it's important to cover for everyone to keep everybody aware of things. So this is the Project Fusion governance model. Basically, what you see is that when we framed the project 5 or 6 years ago, the CEOs of the partners are actually at the top of the pyramid. And below that is the steering committee, which is in charge of overseeing all the activities related to resource allocation, budgeting, and large-scale decisions for the partnership. The committees that might represent the most interest to you as a group would be the Physician Advisory Committee, which is over in the upper left-hand corner there. It's chaired by Dr. Hubert, and it is an advisory body where we review clinical issues of importance. So issues from lower down in this hierarchy escalate to the EPAC committee. And then right below that in the diagram, you'll see what we call regional clinical operations. It's where decisions about how clinical practice or operational activities are going to be changed by EPIC are reviewed and approved. That's where workflow changes go. So if people want to know, well, how did this workflow change happen? Significant workflow changes are typically vetted by both of these committees. The advisory committee and the Clinical Operations Committee, which is the decision-making body. And as I'm fond of telling everyone, none of these committees I've discussed so far are chaired by me. Below that, you'll see the Order Set Committee, the Alerts and Analytics Committee, and the Oversight Committee. Those ones are chaired by me. Those are subcommittees which report up and do a lot of, if I can use the word, grunt work or mechanical, detail-oriented work regarding workflow changes and policy changes. And then at the very bottom of the diagram, you can see we have a series of working groups and application teams, which are even further into the weeds. So like any pyramid, what you can imagine is that issues identified are addressed at a lower level, and each of these working groups or application teams often address dozens of issues and make minor decisions regarding, workflow changes, new functionality. But anything of significance escalates through this pyramid upwards. And one of my jobs is to actually try to make sure that issues, we don't make any changes, make decisions at a lower level that actually have far-reaching consequences. So part of the job is to try to make sure that things that are going to represent significant change escalate upwards through this hierarchy so that the appropriate people are informed. Now, to be honest, sometimes we get it right, sometimes we don't. It kind of depends. So we try to, there's a lot of stuff that goes on. There's just far too much activity to actually have it covered in detail by all the committees. So there has to be a certain amount of discretion to say, look, that decision can be made at a lower level, or no, it can't. And like I say, we don't always get it right. This is to give you an idea of the amount of activity going on at any point in time. So you can see these are the types of requests for change that come in. So some of you are familiar with the perhaps somewhat challenging ServiceNow process, where you make requests for when you identify issues. The safety learning system and the quality team are monitoring for incidents which require changes to Epic. As I said, those application teams and working groups are working with frontline clinical staff to update functionality, update applications, and sometimes that causes a significant amount of work. As I said, the Order Set Committee, the Alerts Committee, and the Oversight Committee all have a role in bringing new issues to the table and adding to the pile of work that's being done by the Fusion team. Then, and we'll talk about this again in a few minutes, Epic upgrades, the new partners, and a request from EPAC, all these things are part of this flow into this committee structure and this governance model. So it is a bit of an unwieldy beast, doing a lot of activity at any point in time. Just to further add to that, to remind everyone that this structure is regional. So this means that not only do we have to recognize when functionality changes or workflow changes are going to affect individual groups, we have to recognize when they affect other partners. So most of these committees, we ask for representation from each of the partners. That's not always possible, but that's what we try to do. And so in the case of the Heart Institute, of course, some of the workflows and some of the functionality is isolated and specific to the Heart Institute, but not everything, right? So consensus has to be arrived at the lower levels, before decisions are made. Now, sometimes we arrive at a point where we say, well, we will build two different workflows because we have to. But ideally, we try to standardize on best practice across the Epic implementation. So that does mean consensus building. So to give you an idea what that means, we're getting ready to go live with our new alcohol withdrawal protocol, which was a pre-existing order sheet that existed before Epic. In the new world, it's taken 8 months of consensus meetings to arrive at a rebuild of the order set associated with this protocol. So because different partners had strong views about how the protocol should be built, and we had to arrive at consensus. Because of that, it was delayed. It was supposed to go live in August. It's actually going live in November. You might hear about it in the next few weeks as we get ready for go live. But this is what it means to run a regional project. And so sometimes I confess it can get a little cumbersome to keep things moving across multiple partners and get everybody on the same page. But that's just a part of the beast itself. This gives you an idea of some of those low-level working groups and application teams that I showed at the bottom of that diagram. So application teams are tied to specific Epic modules. So you guys would be familiar with Cupid is an example of a module or application in Epic. It has its own team of clinicians and analysts who look at enhancements to the Cupid application. And then the other side are working groups, and working groups are typically short-term committees or subcommittees that get together to address a specific issue. And so in my ideal world, we start a working group, it meets for a while, and then blessedly it stops. So some of these have already sunset and are no longer meeting, and new ones get created. So if you wonder, if somehow where these decisions come from, a lot of the basic, if I can use the word grunt work, is done at this level. And anyone who wishes to participate in these is welcome to join us all. But it often is, I say, is quite detailed work on some occasions. So this is an example of just to remind everyone about the resources, because people do comment to me about how things are going. And sometimes I hear physicians suggest that the pace is slower than they would like. So just to be clear that all that stuff I showed is supported by the Fusion team itself. And the Fusion team and the whole portfolio in IS is smaller than those of comparable organizations in the US. And so that can impact how hard it is to move forward with these with physician requests in a timely fashion. And it's going to come up a little bit later, but just to call it out, back in 2019, the clinical training resources were scaled back and the portfolio was moved out of the Fusion team. This was a decision taken at senior medical level back in 2019. Basically, the decision at that time was that departments would now be responsible for physician training. Nurse educators would be responsible for nurse training. University would be responsible for medical student training. The classroom training was discontinued and the training environment was not maintained after that point. And ServiceNow tickets where physicians or other clinicians identify issues have to be looked at by both the digital education team as well as the Fusion team to try to resolve them. So that has been the state of affairs since 2019. Well, I won't comment further about that, but just so everyone on the call is aware of that decision made in 2019 that might have had an impact on support for clinicians. So that brings us to a comment to make sure everyone is up to date on Project Fusion activity. So what's going on right now? Well, some of you may recall we had an Epic upgrade back in March where we upgraded 5. Epic releases new versions every quarter, so we had to upgrade 5 versions from November 2020 to the August 2021 version. Our goal has been to stay about, or to try to keep up to within a year of the current release schedule, but we're not always successful at that. So upgrading in March of this year to August 2021, it was a reasonable catch up. But with Epic, you have to keep running or you fall behind again. We brought in a group health center in Sault Ste. Marie went live on, it's an ambulatory clinic in Sault Ste. Marie. They went live on our version of Epic in April of this year. And so they're another ambulatory care practice that has been incorporated into Epic, and we support them, and they are a new partner. So they have a seat at the table. They're part of that committee structure that I just showed you, and they participate in activities and obviously have their own requests coming into the project. Some of you are aware we went live with the insulin infusion order sets back in June. Some of you may not be aware, we actually implemented the endoscopy module of Epic Lumens in just a few weeks ago in September. So the gastroenterologists and other endoscopy teams, surgical endoscopy and respiratory endoscopy, all transitioned to the Lumens module Epic, including integration of their scopes and the images into the documents. And if you happen to get involved in that sort of thing, you'll find that the new documents are formatted in a more Epic compatible way, and they're easier to find as part of the workflow in Epic now. So that would be an example of an impact you might notice if you're looking up endoscopy on your patients. Yet to come, the Epic the Fusion team is integrating or connecting our Epic environment to 21 long-term care centers. So within the region, I believe there are about 40 long-term care centers in the region, but 21 of them use a standard computer platform, which we're going to be able to connect to for exchange of information. It's sometimes referred to as the Amplify project. This will exchange basic information, so medications, problems, and other types of high-level patient information between the Atlas Alliance and these 21 long-term care sites. This is supposed to go live this week, although I haven't got confirmation. I suspect it's been delayed, but I've not seen an official announcement about that. But anyway, what that will mean is that when you're seeing patients or have been sent from long-term care to the emergency department or elsewhere, there will be some information available on those patients. And when you discharge a patient, the long-term care sites will get information from us after the patient is transferred back to them. Some of you may be aware that we're currently in a code freeze because of the items at the bottom of this page. And this code freeze is in place until early November because of the scope of the November 5th go live. So we'll be bringing in a new lab system. We're transitioning off of Cerner Millennium onto the Epic Beaker platform. The advantage of this is that it's going to streamline clinical workflows. So the particularly in the inpatient world, phlebotomy activities will be much more streamlined, and add-on tests will be streamlined. So in the new world, once Beaker's live, when you go to add on blood work to this morning's sample, the system will first check to see if there's a sample in the lab that can be used to do the additional request before asking for a new draw. So there's an example of some of the tighter integration we get with lab functionality or lab workflows with the Beaker Go Live. At the same time, our lab colleagues have taken this as an opportunity to review, revise, and organize the lab catalog. So stay tuned. There'll be some documents coming out in the next few weeks describing some of the changes to the lab catalog, and that could impact some things you've ordered traditionally. So if the lab decided to consolidate 2 lab tests into 1, if you were previously using one of those lab tests, it may be an impact on your practice when that changes. This is all part of lab rationalization that's been undertaken within the Beaker project. Then the other thing that's happening on November 5th, which is part of the code freeze, is bringing on new partners. So Winchester District Hospital, Kempville Hospital, and Deep River are all coming on Epic at the same time. So that's why it's a fairly big lift to get all that done and to get these sites on board. So that's why the code freeze is going on, because there's just too much stuff going on right now that we don't want to tamper with and put the go live in jeopardy. So that'll be all happening on November 5th. So there will be an outage on November 5th, which will it'll be a short one, but in the middle of the night, but there will be an outage. Going forward after that, we are a project that's near and dear to my heart is called Prescribe It. Basically, Canada Health Infoway, our national health information organization, has been working on electronic prescribing functionality. This mirrors functionality that's been available in the United States for many years, and basically starts moving us away from fax-based prescriptions to true electronic exchange of patient prescription information. So Canada Health Infoway has built basically the integration functionality that allows prescribers to exchange prescription information with pharmacies. And in order for this to go live, both the pharmacies have to agree to participate, as well as different prescribing organizations. With our planned go live in January, we'll be piloting this in our ambulatory care, family practice community at the Ottawa Hospital has agreed to pilot it. It will basically substitute for the e-faxing functionality you may be familiar with today. But instead of faxing the information, it will be exchanged as true electronic data. And ultimately, this will lead to bi-directional exchange. So, for example, when this is finished, when the patient goes to the pharmacy and the pharmacy dispenses the medication, it will update our records to show that the prescription was dispensed, or conversely, we will receive notification that the prescription was never dispensed. That is to say, the patient never filled the prescription. So the enhancement involves data exchange between us as a partnership, so the whole Atlas Alliance, with the participating pharmacies in the community. We're starting small with the pilot so we can learn a little bit about it, but ultimately it will replace the traditional faxing approach that we've been using for many years, and will allow us to exchange information with pharmacists and pharmacies in an electronic way rather than the current faxing back or paging functionality that we've used traditionally. So it's starting small, but it's likely to grow to be a fairly significant change in practice over the next 5 years. We are the first hospital to participate in this functionality, and it's been a bit of a, if I can use the word, thrash to get all the sign-offs required to turn this on. It's been a little bit of a delay in my mind, but in any event, we are expecting, the lawyers are finally finished, so I believe we'll be going live with that in January. And the last bullet on this slide is the Epic Hyperdrive upgrade. So you're familiar that currently when you're using Epic on your desktop, you're using Epic Hyperspace. Hyperdrive is a significant technology upgrade from Epic that requires us to do a fair bit of heavy activity, and it's going to occupy a significant amount of the Fusion resources in 2023 as you get ready for this significant upgrade in the technology that drives all this. So that's stuff that's coming up in the next year. This is a good time to remind you of what the current state of Epic is in Ontario. So by the end of this calendar year, we will have grown the Atlas Alliance from the original 6 partners to 10. I can tell you that there are a number of other sites within the Champlain-Lynn that have expressed interest in joining us. I already mentioned on the previous slide that we will have data integration with some of the long-term care facilities in our region. And with our expansion of the Alliance, it is estimated that 45% of the citizens of Ontario will now be cared for using Epic at the end of this year. And we'll see what happens with other sites. we've been fairly aggressive in being willing to bring on new partners. Some of the other Epic sites in the province haven't been as open as that, but they're also still stabilizing their implementations. So that could have some effect on them. But this is to give you a sense of where we really are. A brief comment about research. I think that I kept these couple slides in because I'm aware, obviously, that the Heart Institute is a leading research organization. So I've said this to others, but basically, my opinion is that the Ottawa Hospital and the University of Ottawa are currently underutilizing Epic's Cohedo research capability. I've just come back from the Epic user group meeting back in August, and certainly other sites, other academic organizations on the continent and around the world are already further advanced than we are with regard to leveraging the information resources we have. I've shared this picture to others in the past, but this is just a bit of a complicated representation of what's going on and what the infrastructure for research really is. So Epic is, the Epic that you know is that cylinder in the center at the top. That's the Epic Chronicles database, which runs Epic that you log into. It extracts and exchanges information with two data stores below it, the Clarity data store and the Caboodle data warehouse. So on a routine basis, the production environment at the top channels information to these other databases that are not being used by frontline clinicians, but rather are available for analytic purposes. And over on the right-hand side, I show an example of all the different tools which are available to allow this Caboodle data warehouse information to be analyzed and used by research and quality initiatives. There are, Epic has a very well-developed set of tools for various purposes. Today, and in Ottawa, most researchers are in the habit of constructing independent databases to collect and aggregate and analyze information, which is in essence a sign that we're not using this information effectively. There's no need to do that sort of thing. And advanced organizations don't do that. They leverage the resources they already have and put all their money into using the tools that are already available. In addition, the other advantage of this workflow that I'm showing here in red is that it's possible then to use this data warehouse and the tools to funnel information back into the production environment. So why does that matter from a research point of view? Well, if you want to identify study candidates, this is how you do it. You extract information from the production database, you analyze it in the data warehouse, and you automate the recruitment activities in the production environment, which is that actionable analytics arrow that I show pointing back into the production database at the top. So we're already doing this in a couple of examples. Very modest examples have been done so far, but some of you may be aware that the hepatitis C team came to us and asked for a workflow where they could have a registry of all hepatitis C patients in the region so that they could reach out to them and try to get them into clinic for curative therapy. So not only did we build them a registry with those tools that are shown there on the right, but we also built alerts inside Epic to encourage clinicians seeing the patients to refer them into the hepatitis C clinic. And so that's an example of how the data flowing down as the warehouse can then be used both for building a registry to have an inventory of all the patients that have hepatitis C, as well as reminders in the production environment, which you may have run into, which pop up and say, hey, do you want to refer this patient into the viral hepatitis clinic to offer them the opportunity for curative therapy? That could just as easily be a message to a frontline clinician saying, this patient is eligible for a trial we're running. Do you want to refer the patient or ask the patient if they'd be willing to participate in a trial? And once again, as I said, this is what other research organizations on the continent do. is the user information in this way. Over on the left-hand side in blue, I show examples of external data. The Epic tools that we have are able to take legacy research databases, that's your existing Excel files and other things, and access databases, geocoding information, genomic information, otherwise, and combine them in the data warehouse, even though they represent external data sources. So that when you combine them, that then means that you get all the data from the Epic system plus any external data that may exist that could enhance or could be part of the patient research activity or quality activity. So that's what the Epic infrastructure is capable of doing. And so far, we've done a few modest initiatives in this area, but I'd say the community has not leveraged this to the degree that it could. I said I just came back from the Epic user meeting. I want to include a brief word about Cosmos. There was a lot of talk about that at the Epic user group. Basically, what Cosmos is a layer below that picture I just showed you, that basically the Epic community can aggregate anonymized patient data from all the participating Epic customers. And that means that if we participate in the Cosmos environment, then we provide or allow access to anonymized patient information, in return for which we can query this database to ask clinical questions and undertake quality or research type activity using this enormous continental worldwide database. Up until now, Cosmos has been an American asset. And strangely, at the Epic user group meeting in August, they announced that the first international customer using or participating in this giant data set is I believe it was Libya, of all places. And we are having discussions with our Epic partners in the province of Ontario to suggest that we should be setting up or moving our provincial customer sites into participating with the Cosmos data set. And that would ultimately give all of you access to information on this scale using those tools I showed in the previous slide. This is once again, both these last two slides are stolen, by the way, from the Epic user group meeting. So what other sites have commented on the value proposition associated with participation in this larger database. So obviously financial, the efficiency and the ability to participate in, as they call it, big data, increase the size of the data set itself, improve opportunities for research, scholarly activity, and patient care, and enhance the quality of the data itself. And I won't go through all the bullets here, but I did want to show that other sites have felt this to be fairly important activity to undertake. And that is something that I strongly believe the University of Ottawa, the Ottawa Hospital, the University of Ottawa Heart Institute should consider participating in. Once again, as you all know, I'm not a researcher, so I'm an advocate. But obviously, I'm not going to use this data in a significant way. But there might be some people participating in this meeting who would benefit from this kind of approach, both the local tools that I showed on the previous slide, as well as the Cosmos tools, if we were to engage and participate in this much larger data set. And it would offer opportunities for us to leverage this much wider data set for patient care purposes, for research purposes, scholarly and quality activities of various kinds. So I'll get off my soapbox for a second, and I want to turn our attention to Epic signal data. This is going to lead to the very tail end of this presentation. So I've already presented this to others as well, Epic basically is able to identify, it tracks clinician activity, and is therefore able to produce profiles of clinicians to show the things that they're doing efficiently and the things that they're not as efficient at. So I've spent a lot of time poking at the signal data to get a sense of how we are doing as an organization. And I'll give you an overview of some of what I've seen. Usually at this point, there's somebody out there who's already getting agitated. I cannot see physician-specific information. I cannot identify individual physicians, so physician privacy has been maintained, but the data can be aggregated and you can see what groups of clinicians, groups of physicians are doing, but I cannot see how an individual physician's practice is functioning. So signal data provides metrics for ambulatory and now inpatient care physicians and comparison to peers across the Epic community. So just like that Cosmos thing I talked about before, this tool is able to aggregate data from our local implementation of Epic and compare it across their much larger aggregate information, not for patient information, but rather for providers and how providers are managing their day in Epic. This was all built as a response to pushback that suggested that electronic health record systems were contributing to a drop in physician well-being and an increase in physician burnout across the community. And so Epic built a lot of tools for trying to understand where physicians were struggling and how it might be possible to assist. So when you look at signal data, basically what you see is there's sort of 5 categories that I focus on. When looking at it, there are metrics describing physician proficiency with in-basket, the number of physician messages each physician receives, how long they spend managing messages, the profile of the messages themselves. And I can tell you that when you look at different divisions, the profile of messages changes. So I'll just to rat out the oncologists. They seem to spend a tremendous amount of time dealing with messages from the chemotherapy suite. And so they're getting in-basket messages all the time related to their patient population, whereas the endocrinologists are getting lab results all the time, and so on and so on. Orders, you can see how much time individual or groups of physicians spend on ordering an Epic in the ambulatory setting as well as in the inpatient setting, and how well physicians are using their preference lists to accelerate their ordering practices. And when I look at most divisions and departments, the physicians, some divisions, they aren't using preference lists very well at all. And if they are using preference lists, they're not defaulting or editing their preference lists to save them clicks. So the Epic signal data can tell you that. Documentation gives you a sense of how long each physician's notes are and how much time they spend doing their documentation in comparison to their peers across the world. Now, your group would be easy to compare to peers, whereas some groups are harder to map internationally. That is, practices are so variable that the comparators aren't meaningful. So you have to always take these type of data. It's data, right? You have to take it with a grain of salt. But you can see which tools physicians are using. I can see when I look at the data, some groups of physicians are, well, they're typing. Like that's all you can say. You look at their notes and you can see they're spending a tremendous amount of time typing. And then you wonder, or people wonder, why they're angry. Well, if they're feeling they have to type their notes in Epic and they're not particularly good typers, that's fulfills the accusation that Epic has turned them into clerks. Well, they shouldn't be typing, is the short answer there. But the data shows that we have divisions where typing is a significant part of their documentation activity, which seems very unfortunate. Review is the time physicians spend searching for information, and there's tools in Epic that can speed that up. And Pajama time is a metric that I find particularly important when I look at Epic, because Epic maintains a profile of when each physician is working Epic and how much time they're spending in Epic after hours. So after hours work on patient care was identified in the literature as pajama time. That is to say, this is time physicians are doing clinical work after hours when they should be with their family or doing other things. And Epic collects data on this, and I'll show you a few overviews in just a moment. So this is the high-level overview. Epic provides this signal data, and you can break it down by site, by department, by specialty, by subspecialty, and so on. So you can drill down further and further, and it's an example of the 4 first quadrants: in-basket, orders, notes, and letters, and clinical review. And basically, the way Epic codes it is, any indicator that's red means that the individuals within the set are outside of the or in the top worst, if I can use the word worst, quartile. If it's green, they're in the best quartile, and if it's blue, they're in the middle 2 quartiles. So in this example, you can see that this group is spending more time than their peers in basket, 15 minutes per day. They're doing they're on their average for their orders activity. Although you can see there are some other red indicators that you can drill down in the orders sub data to see where they may not be using orders as efficient as they could. They could be even better, in other words. If you look at notes, the time spent in notes is per day is good for this particular group, although documents are fairly long by Epic standards, and in the 7K range. Interesting to note, as I said, I was at the Epic conference in August, and they showed that American clinicians' notes are 4 times longer than the notes of the rest of the world. The data was just shocking to see how much they document there and what a heavy burden it is. Not really Epic related, but clinical practice related. And there's the clinical review metric over there. To give you an idea of what some of this data provides, here's an example of drilling down into documentation. You can see the time spent in notes per appointment, per day, per note, and the length of the documents, and you can see the profile of how people are producing their notes. This is some of your colleagues, and although I know it's anonymous, and you can see that this particular group is making good use of smart tools, copy and paste, and voice recognition, and manual documentation is quite low, which is good. As I said, there are some divisions and departments where that is not the case, and voice recognition and smart tools are underutilized by some peers, and that's certainly could be a source of frustration for some people. Orders, here's another example, drilling down into orders, showing the time per orders per appointment. So if you're taking 2.8 minutes to do your orders, it's probably too long, which means that this group would benefit from more training about how to use orders more efficiently than they are. So even though they're, 2.8 minutes isn't that bad, it should be better. And so that's where we have an opportunity to improve people's efficiency, and if not make them happy, at least make them less unhappy. And this is the Pajama time data from, once again, a group of your peers. I selected some extremes. So basically, when you look at Pajama time, you're looking at the day, the time of day is on the horizontal axis, and the Epic activity is on the vertical axis, broken down by which type of activity this person is doing. So in the upper example, we have someone who's very busy in Epic during the day between those 2 dotted lines, does a little bit of work in Epic after hours, but basically finishes off without a lot of Epic investment in the evening. Whereas the person on the bottom has what I would call a fairly horrifying picture of working through the day on Epic, then working after in the early part of the evening, then looks like they take a break somewhere around 8 o'clock, then they go back on Epic till 2 a.m. Well, unless this person is really likes working in Epic, this is a very bad picture. This suggests that this person this looks like burnout to me. This is like not what is supposed to be happening. So this is an example of somebody who needs to have we need to have a conversation with. Well, first of all, the division head would need to unmask this person, identify who this is, talk to them and find out what's going on, and potentially this person would benefit from additional support and training so they can spend their day more effectively and not be working all night in Epic and cursing my very name. So that the signal data gives all of this sort of profile of what's going on. The names of the physicians are redacted, so I cannot identify these individuals, but the division department heads can. And so to finish up here, the message I would have is that here we are, we got through the Epic go live, we seem to have survived the pandemic. Now is a good time to turn our attention, well, it's past time to turn our attention to one, leveraging the research functionality, which I mentioned earlier, but more importantly, to ensure that we provide training and support for physicians so they become more efficient in using Epic and don't spend their day like you see in this picture, unless they truly wish to. I did speak to a surgeon who said that he always brought his charts home in the old world before Epic. That was his practice. He'd worked all day, did the OR, they brought his charts home at night. And he said, at Epic, I do the same thing. And it didn't bother him. I go, all right, if that's what you like to do, that's okay. But I suspect that there are a number of people who feel they've been forced into this workflow by Epic and are justifiably unhappy with that prospect. So I'll skip ahead to the last slide here. Last two slides, I guess I should say. Before I leave a few questions here. My message to the hospital leadership for the past 2 years has been that we need to address what I see in this data and what we see in the wellness survey, the nasty emails we get, and so on, and take them seriously and address the justifiable concerns the physician community has brought up. And so many Epic sites find that physician support and enhancement training, mastery training, as it were, is really important. And so the types of things, the buckets, as it were, that we should be addressing are a number of different tools I show in the column on the left side there. So instead of a round like we're doing today, I would offer the opportunity to have what we call bitch and fix sessions, which is where we would bring some of the Epic analyst team and leadership, or the Fusion analyst team and leadership, as well as myself, to participate in open conversation with a division such as yours, to identify the issues, to exchange information, to hear what people have to say about things they'd like to be addressed. Some of them might be possible, some might not, but at least we'd hear what people had to say, as well as offering and reminding departments or divisions about things they could do to enhance their day. There's online training. Epic provides a number of videos. We've produced some videos or e-learning modules. I know people are never thrilled with that type of conversation, but there are some things people could benefit from. We need to get back to classroom-based training where we identify issues. So if a group of physicians are having trouble with their order preferences, we run a session at a time of your choosing where physicians can spend some time hands-on in a classroom type setting, reestablish our classroom type setting to allow physicians to practice setting up their orders or their documents or their in-basket in a way that makes their day more efficient. Virtual training can be done, not perhaps quite as effective as classroom-based training, but could also be a helpful adjunct. Epic does some of these sessions remotely. And then ideally, we would have training resources who could actually visit clinicians or clinical areas and see for themselves what the practice is, what the issues are, possibly provide some enhancement to the, in real time to people who are doing their work, and then take away issues back to the Fusion team that could be addressed at a later date. So this slide I'm showing is part of a document I drafted for the hospital leadership, well, almost 2 years ago. And it's certainly my belief that the changes to the way we do training were perhaps not as well thought out as they might have been. And we need to reestablish a training team that can formally address physician efficiency and wellness. I've been on this message for a while. I certainly suggest that you, your department, your department, your organization engage in advocating for this type of approach with hospital and medical leadership. So I'll stop there and try to leave some time for questions. Sorry, I ran a little bit over.
Thanks so much, Glenn. There's a couple of comments in the chat. And I have a few questions lined up as well, but just to come back, so, I think the last section really highlights some of the points you've made. And I think all these initiatives for training will be appreciated. And actually, David wanted to ask why there isn't financial support for training of physicians. And so I don't know if what you're proposing here does imply that there's going to be some of that. And then maybe you can answer that. But the other thing is when we went to Rush beforehand, and you will remember that visit, Rush had identified 9 physicians who basically 50% of their time was their clinical work, and 50% of their time was actually dedicated to making sure that all the other physicians were up to speed. And so taking the data that you showed, looking for people who are falling behind in one area or another. And I don't know that comparing peers to peers is necessarily all that helpful because of differences in workflow, but for an individual to look at the things that they're behind on and can improve upon, if they can get training in those areas, I think that's very helpful. The classroom training is good, but I'm not certain it even is as good as kind of individual stuff. So again, kind of back to the question about what is going to be the investment for training.
Well, you've described that perfectly. So the decision back in 2019 was all about money. So the disbanding the training team was, basically it reduced the budget. And so there was no budget for anything since 2019. And so there's been a lot of conversation. I keep referring to documents that I've sent to the hospital leadership, expanding on this slide you're seeing here. And it's basically to advocate you need to put the budget back, because if you want to do this, you can. And I take it even further. So one is physician satisfaction, of course. Physicians don't like to do training. They don't like to take time out from clinical work. They don't like to do e-learning modules and so on. But the fact of the matter is that it impacts their efficiency of their day, their mood, their wellness, and all that. But the second part is, if you don't maintain the training of not just physicians, but nurses and med students and residents, you're also putting the patients themselves at risk. If somebody, and I see examples of this in the data analysis, the incident analysis we do, is where some of Epic functionality is quite complicated. And if people are unfamiliar with the workflows, they can do things that make their own lives more difficult. We've had nurses or others delete orders that shouldn't have been deleted. We've had med students or residents activate things that they shouldn't really have activated. So in addition to its impact on physician wellness and their efficiency of their day, not having clinicians up to date on how to use Epic as effectively as possible also impacts quality and safety. So all these things are reasons why I've been advocating to reestablish a budget. And Rob, I take your point. I will be discussing this with Dr. Gartke later on today. And I do think you're right. Establishing a cadre of physicians who can support their colleagues. We would never have enough for every division, but we might have some. And I think, so I will take your point, but you're right. That should be another part of this.
So I think and you're seeing comments in the chat about, being trained by medical students and high school students, and so on, and the lack of sort of standardization of the training. I think those are valid comments. I think there's a lot of people who were brought in to be, and they did know the system, and I think it helped us to get things going. But I think, you need physicians to train physicians and nurses to train nurses and so on, and so on.
Yes, and I think those comments are all valid, and I mean, we're obviously not going to revisit the go live and so on, but I don't have any disagreement with what I've heard.
Yes. Okay, so there's a couple of questions here, and I share this concern about the false diagnoses entered. And I can tell you as well that this affects when you're trying to get data, which we're trying to do related to the transition, and among other things, when false diagnoses and sometimes what useless diagnoses. I agree completely with David here that the patient wears glasses. That is a diagnosis in the history. Like some of those things, I don't know how we streamline that better. And truthfully, that data is actually potentially useful, but because there's an inconsistent approach to it as well. That's another problem. So some people who use the problem list, which helps us with our potentially with our RIW and other things, others don't use it at all and use other templates. And so those problems don't necessarily get entered into the problem list, but then the problem list has things that are really not useful, like wearing glasses. So
right.
I agree with
and
that.
So that's this is an important conversation. Perhaps we should all think about a follow-up activity in this area, because I haven't covered it in my slides. Basically, I've been a follower of problem-oriented documentation since its inception a long time ago, and all the comments I just heard are valid. So our challenge there is not just an EPIC efficiency or proficiency issue. It's the University of Ottawa we need to transition to teaching problem-based documentation if we wish to be able to use it. And so that involves not putting in, if I can use the word, stupid things like the patient wears glasses. And it involves often what I say to the house staff is, it's okay to put in an initial diagnosis, but you have to go back and fix it later. And that kind of culture, that kind of education does not currently exist at the trainee level, at the university level, and so on. So if we wish to address this issue, in addition to some of the things I just said about, or we talked about physician support and enhancement, mastery training, we also need to address education around how to use problems more effectively. And we need to get everybody, if we're going to do that, we all have to participate. So we all need to take responsibility for it. So I certainly see problems that are just a dog's breakfast. So I do think there's something to be done there in addition to what I'm showing on my slide.
Yeah. So a couple more questions here. Is there a way to edit the medical history and order the diagnoses? And I'll give a short answer to that. That's from John Fulop. And so the answer is yes, there is. You can prioritize the diagnosis list in the problem list, but it's not so it's not so discernible. Like you can have things, it will rank them high, medium, and low, but if you put several in the medium, it may not be in the order that you want. So I share that concern, but it's still possible to do it. I will say that there are some templates like our residents use. This, this kudos to Ben Hibbert, who set this up a long time ago, and uses a very, very logical step for cardiac problems, but it's not interfaced with Epic. So, and the way the problem appears in Epic is frustrating, I think, even though many of us do use it. So I'm not certain what sort of solutions there are for this type of thing. And because this is kind of a broader Epic thing, it's not specific to us. I don't know if we can make those changes. Glenn, can you?
I think that you described it right. There's some function in Epic that allows us to do this. I think same thing is we need to make sure everyone is very familiar with the way Epic can support problem-oriented documentation and use the tools effectively. And then I think there's an educational component about, getting everyone to understand what's a problem, what's not a problem. And what I see is people duplicate problems, like the problem's there 3 times. And I think that's bad for 2 reasons. One is it's clutters, but also people went to the trouble of putting in problems more than once. And well, that's wasting their own time. So I think there's a lot of issues around this. I'm glad to see your group is enthusiastic about this area. I talked to other groups and they could care less. And I think it's actually an important part of documentation. I think it can make your day more efficient, but we do need to be better at it, I think, collectively than I think we are today.
Yeah, and just we're past the hour, but just one other comment from Manika, who I also agree with. There's now this cut and paste ethos for clinical notes. So taking a prior note and cutting it over and bringing it over. And Epic actually enables that in a way. There are tasks or places where it actually gets encouraged to do that, to bring over notes. And certainly it helps when you're covering the ward on the weekend. You don't know the patients, and you're pulling forward notes from the previous day or whatever. So it does help that workflow. But is it problematic? I think it can be, and you still have to kind of go in and update things, etc. And I don't know if you have any comment about that, Glenn.
Yeah, so the Epic term and the international term for this is called note bloat, is the word for it. And Epic actually has a course on this to combat note bloat. Now, what we see in this world is nothing compared to what the Americans are doing. Like in the United States, it's madness. But even here, there are people who are duplicating information, which in essence makes the note longer than it needs to be. And this is, and you're absolutely right, Epic, there are places where Epic encourages this practice. So same thing is, I think, in addition to talking about how we use educating ourselves about how to use Epic efficiently with problems, I think there's an educational role, not purely just focused on physician proficiency, but rather one focused on let's say, physician practices in documentation and avoiding note bloat. And I'm going to pick on the house staff for a second. They paste in the whole goddamn CT scan report. And I go, really, guys? How about the relevant sentence, for God's sakes? But the whole thing is pasted in the note. And, and they're just doing it, 1, because it's quick, and 2, because they're fearful of leaving something out. That's, and Epic encourages it, right? So I think we have an educational task here, and we could lead that within our organizations. I don't think the training team or training resources are going to do that for us.
So it comes back to I think the point that David was asking or wanting us to ask. So all of these things to me are things that can be done, and we can make ourselves better and our care better by learning more how to do it. None of us has the time to do that. So to find a strategy and to get the support from the hospital to be able to do this, to support people to actually train. And so just to come back to that, so do you think that that's coming? That's really
I think
the
there
question.
are, I'm hearing some positive things in the conversations today suggesting it is coming, but I would still strongly suggest advocacy. So yes, I think we're making progress. It's been a long time, but I think we're making progress finally, but I would not let up the pressure.
Well, thank you, and we would encourage you to keep up the pressure too, and we will, I think from our perspective, I think you can see from the chat, and you know, we've got great attendance this morning to be watching you, Glenn, on this. I think it's something that's, it's affecting all of our lives and all of our care. So as much as we can make ourselves better, we're going to be wanting to support that.
Well, thank you. I completely agree.
All right, so we're well past the hour. I apologize that we're a bit after the 8:30, but I think it shows you the importance of the topic, and we really appreciate you coming, Glenn, to give us the update. There obviously, there's still many other questions people have, but you know, and like you say, maybe there's going to be opportunity for the bitch and fix sessions and other opportunities to give feedback and ask questions and help ourselves to be better with Epic and our care. Thank you again, Glenn, and have a great day, everyone.
Bye-bye.